All right, our next speaker is Dr. Ali Banayosy. Dr. Banayosy spent many years at a center in Germany, Bad O, in a time when all of us were putting in 1, 2, 3, 4 pumps at a time. He was putting in many, many pumps at a time. I'll never forget, there was a famous picture of all of his TLC2 driver patients standing around in a circle outside. I'm like, this is crazy. There are so many outpatients. It was insane. So Dr. Banayosy came to Hershey, Pennsylvania, coming up on 7 years ago, and is 6 years ago. And it brings a different model to the care of the ECMO patient, as he is an intensivist. So this is a really interesting perspective on ECMO patients from an intensivist from one of the busiest ECMO centers in the world. Let me just mic you up.
You can try it, or I can point it more towards you.
That's on my fingernail, not you.
I didn't do anything.
I know you didn't. It's all me.
Okay. No one is around. Oh.
I know. It's very crispy sound.
Okay.
Try the remote.
First of all, I would like to thank you guys for inviting me to come here to share our experience on ECMO and we had in the last 6 years in Hershey Medical Center. And probably ECMO is something not as a VAD coordinator, you are not familiar with the ECMO every day. You're dealing with VADs, you're dealing with total artificial hearts or BiVAD and so on. But ECMO, for many of you, probably something you didn't deal with. Probably very few of you dealt with that. That's why I'm going to start with some, but before I'm going to start with my presentation, I would like to underline how important the VAD coordinators in our daily life in managing patient, a VAD patient. As we start with the VAD program in Bad O, we start in 1987, and we put the first job description for a VAD coordinator. At that time, many centers were trying to get a VAD coordinator. Many of them were perfusionists, and not too many were at that time came from nursing background. I remember when we started to write the job description, I insisted to have for the people who applied for this job to have a nursing background, because they are going to deal with the patient as well as with the machine. Perfusionists dealt only with the machine and didn't pay attention to the patient, but people with nursing background put the attention to both of them. That's what we need. And I appreciate the work you guys doing in all that success we achieved in the field of mechanical circulatory support. Without you guys, we wouldn't be here today and talking about destination therapy and talking about 5-6 years survival rate of patients living in the community with VADs. Thank you. Back to my presentation, and again, that's talking about different topic, not VAD. Thank you. That's my background. As I did most of my work in Germany. I moved from born in Egypt and moved in 1980 to Germany, and I started in Bad Oeynhausen in 1984, and we built very active mechanical circulatory support and heart failure and heart transplant program. We were performing about 4,500 open heart cases a year, and about 80 to 100 VAD implantation a year, about 80 heart transplantation a year. And I moved, please, next slide. And I moved 2008 to Penn State. And as you see here, that's the activities we have in Hershey. Started 2008 here. We have been able to increase our activity. We're doing that more than 100 cases. Half of them are VADs, half of them are ECMOs. Please, the next slide. I'm talking about ECMO. What that? ECMO stands for extracorporeal membrane oxygenation. That's, please, the next slide. Can I?
Yes. Pass that back to Don.
Yeah. That's the next slide. Okay, what is the conditions we might consider patient for ECMO? Which condition? That we have patient with advanced cardiogenic shock, and I'm going also to define the advanced cardiogenic shock. because I'm differentiating between patient in stable shock and advanced cardiogenic shock, or patient with advanced respiratory failure, patient with cardiac and respiratory failure, and patient with high-risk cath lab procedures. That's the 4 conditions. That many other underlying disease you might see if patients suffer from cardiogenic shock or advanced respiratory therapy, but that's the main group of patients we are going to deal with them. I'm going to concentrate today about advanced cardiogenic shock because that's going to be beyond the scope of this lecture to talk about all types of ECMO and all the indications. That's why I'm going to concentrate today on advanced cardiogenic shock. Please, the next slide. We have 2 types of ECMO, just to start with. That we have the veno-arterial ECMO and we have the VV ECMO, the veno-venous ECMO. The veno-arterial ECMO is supporting the heart and lung, or the heart alone. And the veno-venous ECMO is supporting only the lung. We have to understand, with the veno-venous ECMO, we are not adding any support to the heart, supporting only the lung. With the veno-arterial, we are supporting the heart, if the heart required to be supported, or the heart and lung as well. Please, the next slide. And that's how ECMO works. We are sucking blood from the right atrium, which is usually less saturated or unsaturated blood, and we're introducing a cannula through the femoral vein to the right atrium, sucking blood from the right atrium, and this blood is going to go to the pump. The pump is going to push the blood through an artificial lung, the oxygenator, and returning the blood back again to the descending aorta or the femoral artery. Can you?
It's a good thing we've got so many band coordinators.
No problem. Can we get back? Slide back. Slide back. Yeah. That's the most common way we're applying ECMO. There's other ways to get an access to the ECMO. You can use the axillary artery. You can use other, if you are in the operating room and the chest is open, you can use the right atrium and aorta. But we are talking here about percutaneous ECMO, which we are usually utilizing the groin vessels, and we applying the access in a percutaneous way without cut down, and you're going to see that later on in my presentation. Please, next slide. Okay. If there is a need for mechanical circulatory support in advanced cardiogenic shock setting, why we are looking for ECMO, why we're looking for Impella, why you're looking for tandem heart. And there is place for ECMO. Please get the next slide. We still have many people are dying from cardiogenic shock secondary to acute heart attack in the United States. Please, may you get the next slide? If you see the numbers of patients are dying after acute heart attack, we have about more than 1 million people dying in the United States. And if we look to the age of people dying below the age of 75, which might consider them for any form of mechanical circulatory support, we have more than 675,000 people dying from that. That's I'm talking about patients who was only dying after suffer from cardiogenic shock following a heart attack. We have, please, the next slide. We have other patients suffering from acute cardiogenic shock having different etiology. We have patients with following cardiac surgery. We have patients with fulminant myocarditis, patient with acute decompensation of cardiomyopathies, patient with postpartum cardiomyopathy, congenital heart disease, and so on and so on. That's a big list of patients, and many of them dying if they are going to suffer from advanced or severe cardiogenic shock if we're not be able to treat them appropriately in a timely way with any form of mechanical circulatory support. That means we still have place here to improve. We have many patients are dying everywhere if we are not going to capture them in a timely way and put them in a form of mechanical circulatory support system. And if you look here, that's the shock trial, is that when they applied the early revascularization and compared early revascularization versus medical therapy, early revascularization improved the success rate of the survival rate of patients suffer from cardiogenic shock following acute heart attack. But if you look here, that's the survival rate. So at 30 days is still 50%. Please, the next slide. And looking to other trials, try to utilize devices for managing of patient with acute cardiogenic shock. That's here. Most recently, a trial was done in Germany, compared and randomized trial compared the patient supported with balloon pump versus patient managed medically. Please may get the next slide. The next slide. There's no improvement in the survival rate of patient treated with intra-aortic balloon pump or patient treated with medical management. There's absolutely no difference between both group of patients. Also, there is other trial. Please, next slide. Look to randomized patient between intra-aortic balloon pump and no, the next slide, please. That's here. This trial compared patients supported with a tandem heart versus intra-aortic balloon pump. There also was no significant improvement in the survival rate of patients supported with a tandem heart. The next slide. That's the next slide. That's here also trial compared patients supported with the Impella machine or Impella LVAD, and they found also no survival benefits. There's unfortunately no trial compared ECMO with medical treatment or ECMO with other mechanical circulatory support system. I hope that in the near future we'll be able to do that. That means here with the device we have right now, we were not able to produce or deliver a significant improvement in patients suffered from advanced or cardiogenic shock. Please, the next slide. That's here the data from the Impella trial. Please, the next slide. Now, we have a big dilemma here regarding cardiogenic shock. If you look to that definition here, that which most or all those trials I presented today utilize this definition to include their patient in the clinical trials, which is, sorry, that's the patient, I am calling that here patient in a stable cardiogenic shock. If a patient here has systolic blood pressure below 90 and for 30 minutes and started to require inotropes for more than 30 minutes or intra-aortic balloon pump and having heart rate above 60 and wedge pressure above 15 and cardiac index below 2.2. There's many patients going to fulfill this criteria. Not every patient fulfilling this criteria is going to need a balloon pump or going to need Impella or is going to need tandem heart or ECMO. I'm not talking about this cohort of patients. They are stable and the survival rate should be much, much higher than 50% regarding to this patient. Please, the next trial. I'm presenting here two case scenarios just to underline the differences between that patient fulfilled the definition I just presented and patients suffering from advanced cardiogenic shock. Looking to this case here, we have 71 years old female patient with acute MI cardiogenic shock, past medical history of diabetes, had an emergent PCI, arterial blood pressure is 100 to 50, and the patient requiring intra-aortic balloon pump and epinephrine in low dose and central venous pressure of 11, lactate of 3.5. That patient is, that's certainly she's in cardiogenic shock, but still stable shock. Looking to this, please, next slide. Looking to this case here, that's 69 years old male patients, also acute, suffered from acute MI cardiogenic shock. The patient required intubation, bradycardic, requiring external pacer. Started to, because of bradycardia and all the stuff, he underwent an PCI, got perimeter stent to the BDA. Despite the intervention, he's remained hypotensive, hypoxic, and has severe metabolic acidosis. Please, the next slide. If you see that this patient now have a lactate of 10, central venous pressure of 22, arterial pressure of 90 over 40 despite the balloon pump, epinephrine, dopamine, vasopressin. These two patients, are they having the same outcome? Certainly not. Can those patients have this? If we're going to talk about mechanical circulatory support devices, can I apply the same devices to both these two cohorts or these two patients? Certainly not. If I'm going to put the first patient, this patient on Impella or tandem heart, that's because of the severe right heart failure, that's not going to work. This patient needs certainly more cardiac output than the 2.5 or 2 liter Impella or tandem heart is giving me. This patient needs higher cardiac or pump output to salvage them. That's why it's very important to know what kind of cohort of patient we're talking about and to try to select the appropriate device for the appropriate patient. Please, the next slide. I'm presenting these two pictures from these two kinds of patients. That patient is suffering from cardiogenic shock, but he is able to read the newspaper. This patient now started to suffer from severe multi-system organ failure secondary to the cardiogenic shock. And certainly, the outcome of these two patients are different. Please, the next slide. And that's here we're trying to define and to put that definition for us. And we said ECMO is going to be considered on patients suffering from advanced cardiogenic shock. Patient already got the intervention and remain inotropic dependent for at least requiring 2 inotropes and having all the other criteria for the stable cardiogenic shock to be considered for ECMO. That by definition, those patients are going to have, at the time we are considering them for ECMO, higher mortality rate than the patient in the stable cardiogenic shock. Please, the next slide. And here's a slide from the second patient I presented. When this patient, as you remember, he was having lactate of more than 10. When we put this patient on ECMO, as you see, his down regulation from lactate went down to below norm. And also his pH improved from below 7.2 get to normalized. If that's because of the restoring of the circulation, because we perfuse now the organs and perfuse the patient in appropriate way. Not many other systems could be applied percutaneously would achieve that kind of stability on those patients. Please, next slide. And as you see here, the patient was a multi-system organ failure. His LT was above 2,000. AST was also high. And after applying of ECMO to the patient, that's the down regulation. It is recovery. We have to. That's one of also the goals we have on those from applying of such kind of system to not only to look about to care about the heart, we're caring about the other organs as well, because we'd like to patients suffering from severe advanced cardiogenic shock, they're going to only the heart is not going to fail. We have certain degree of multi-system organ failure, and we have to care for the other organs as well. Please, the next slide. And that's our goals from the devices we need to be applied in such kind of patients suffering from advanced cardiogenic shock. First of all, we would like to restore the circulation. That's number one, with enough cardiac output. And number two, we have, because we would like the heart to recover, we have to have a device which is also giving us, or giving the heart a chance to be unloaded to enhance the myocardial recovery. ECMO is not the best device in this way, but the best we have in our hands. And there is a way to unload the heart in clinically meaningful way with the ECMO. We have also to wean the patient from the toxic doses of inotropes. All those patients coming to us in severe or advanced cardiogenic shock have multiple inotropes, and would like when we apply the circulatory support system on them, one of our goals is to wean from these high doses of inotropes because of their side effects, and eliminate the cytokines and reverse the multi-system organ failure. Please, the next slide. We see that here we need flow. That we know that from the VADs, we know that from the total artificial heart, why the patient are improving, because we're giving them again flow. The same thing for ECMO. We need high flow. And high flow here, at least 4 or above 4 liters at this period of time, the patient need to recover. And that's why other devices like tandem heart or Impella is not able to give us such kind of flow for appropriate period of time. And also the ideal device should allow for clinically acceptable left ventricular unloading, as I mentioned before. Easy and fast deployability. That means we need to have a device I can put it everywhere. Even if we are here in this backyard here, if a patient requires that here, we can do the ECMO here without going to the cath lab. I don't need to go to the cath lab to restore the circulation, again, like in case of tandem heart or the case of Impella. Also, I can say many patients suffering from advanced cardiogenic shock, it happened to them in not in university level hospitals, and sometimes they are unstable to be transferred to hub centers. In such kind of cases, we are flying to this patient or driving to them and putting them on ECMO there, and then after transferring those patients to hub centers. That's why I need a device. I can use that, and I can without having going to the operating suite or to the cath lab. Also, this device should give us LVAD, as well as, if we're talking about advanced cardiogenic shock, certain degree of right ventricular support. Also give us short to mid-term support, because if the heart is not going to recover, I would like also to give the patient and the organs time to recover, to allow us to assist those patients if the heart's not going to recover, for other long-term expensive therapy like LVAD or BiVAD and so on and so on. And allow for inter-hospital transfer. As I mentioned before, those patients might suffer in small hospitals from cardiogenic shock, and I would like to transfer them to hub centers. Also, the biocompatibility is very important, because if I don't have biocompatible system, I will not be able to run this pump or this system in a patient for appropriate period of time to allow for organ recovery. And the cost, we shouldn't forget about that. Please, the next slide. What's our goals when we're putting a patient on ECMO or such kind of devices? First of all, we would like to achieve recovery, and the best thing that this patient, his heart, his organ is going to recover. We can wean, and the patient, he can go home with his own heart. If that's not going to work, if that was because of the massive myocardial infarction or other underlying disease and the heart is not going to recover, we have in some patients going to be qualified, and we can assess them, could be qualified for long-term bridge to transplant or as a destination therapy. Because of the long waiting time for cardiac transplantation, ECMO is not a suitable bridge in the United States. Probably if you work in some other countries might have shorter period of time for waiting for a heart, you might utilize the ECMO as well. But it's not an option for us here. Or unfortunate situation, if we have a patient, you put him in ECMO and turned out to be brain dead for any reason, you can use those patients and utilize their organs to help other patients as well. That, at the end of the day, you're going to win and to help some other patient, even if you will not be able to help this particular patients. Please, the next slide. Why the ECMO in advanced cardiogenic shock, and why not other system? Please, the next slide. As I mentioned here before, the ECMO is the best we have. It's not the ideal, but it's the best we have because of this reason here. It's giving me enough flow, is having acceptable left ventricular unloading, and that's something, if somebody have a question in that aspect later on, I'm more than happy to discuss with him how we are unloading the left ventricle and utilizing the left ventricular, the rest of the left ventricular function to unload the left ventricle and inotropes as well. And there's other methods like to go with the septostomy to unload the left ventricle. There's a way to do that. If you know how to do it, it's going to work. And also giving you right heart support, giving you pulmonary support is at the bedside implantation, you can do it. Also the duration of support, we have patients supported for 90 days with ECMO. And the insertion is percutaneous. That means we don't have a lot of bleeding complication and less invasive compared to other devices could be applied at that time, particularly the LVADs here. We are not utilizing VADs for such kind of patients suffering from multi-system organ failure. We're not going to with them to the operating room and opening the chest. Bleeding is going to be a big complications. Infection is also other things we have to think about, and we can achieve similar or even better effect with the percutaneous ECMO. Please, the next slide. Well, when I'm talking about ECMO, please understand, because some of you dealt with ECMO in the past or show some other ECMO circuits. I'm not talking about this antique ECMO circuits, which might require a village of co-worker to manage the system, not to manage the patients. If you're going to have somebody managing all that things you need to run the ECMO, that's not going to work. I'm working about the other, the new generation ECMO circuits we are utilizing. Please, the next slide, which is utilizing centrifugal pumps, that means having better biocompatibility, also utilizing low resistance, low pressure drop oxygenators, having low resistance. We're going to introduce the shear stress for the circuit, simplified system, simplified tubing system. We don't need bridges or other connector to the tubing we are using. No side ports. Heating and cooling devices could be connected to them. And because of the new technology we are utilizing nowadays, this allowed us to reduce the level of heparin, the circuit requiring to run the ECMO circuit. We are running PTT between 50 and 60, and that reduced dramatically the bleeding complication, many other complications we had in the past with the ECMO circuit. Please, the next slide. As you see here, that's all what we need is the venous axis, arterial axis, that's a pump, maglev pump, and oxygenator, and that's it. There's no connection, no hemofiltration connected to the circuit, and with this circuit, with this simplification, we have our nursing and NP running the ECMO program. We don't have perfusionists 24/7 to run this program. We're also adding economical aspect to the ECMO program. Please, the next slide. The way we are doing at the bedside here, that's here the way we are cannulating the femoral artery antegrade in antegrade way to prevent the lower limb ischemia. Please, the next slide. That's here the cannulations. That's the arterial cannula. That's going here to the femoral artery, and that's here the antegrade cannula here to perfuse continuously the lower limb, because we introducing here 17 to 19 French big cannula in the femoral artery, and we are here through the side way. We are taking blood from here and perfusing the blood downstream to perfuse the lower limb. That allowed us to run the ECMO for a longer period of time without having lower limb ischemia, which is one of the big disadvantages we have in the past, and that's the femoral cannula here. But since you see here, nicely cannulated, there is no cut down, and patient, we have weeks without big problems in our institution. And that's the way we are running it. If you compare the first picture from the ECMO circuit I presented here a minute ago, and the way we are running the ECMO now, that's a big difference. And that's the machine, and the oxygenator is hiding here behind the machine, and that's the colleagues required to manage the patient, and the perfusion is coming once a day just to look to the equipment, but not 24/7. Please, the next slide. That's here, as you see, patient extubated while they are in ECMO. This patient here had a heart transplant 4 years ago, and because of gastrointestinal problems, she was not able to take her immunocompromising drugs, and came to us with rejection, and came to us in advanced cardiogenic shock secondary to rejection. We put her in ECMO for 6 days, and after adjusting her medication again, her heart recovered and has been weaned from ECMO. That's the way we are doing that, and that's here again patient on ECMO, and that's with this simplified ECMO circuit we have been able to transfer intercontinentally patients from Saudi Arabia to Hershey Medical Center. Please, next slide. And that's one of our patients, one of our first patients in Hershey Medical Center, that 28 years old patient came with peripartum cardiomyopathy, required ECMO for 14 days. Her heart recovered, and she went home with her own heart. She is now 5.5 years with her own heart. Please, next slide. That's also one of our patients with primary graft failure after transplantation, required ECMO for 6 days, and also recovered. But as you see here, you can able to talk to the patient. Patient can eat while he is on ECMO. If the biocompatibility of the circuit is not good, you wouldn't be able, you wouldn't see that recovery. You wouldn't be able to extubate the patient while they are on ECMO. I had my experiences past with the first generation ECMO. We were not able to extubate the patient like this. It's totally different. Please, the next slide. That's also one of our patients here who suffered acute cardiogenic shock, severe, and a big VSD. He was on ECMO for 8 days. He was extubated. We talked to the patient about his options before going to the operating room regarding repair the VSD or a total artificial heart, and the patient agreed on that. He is 75 years old patient. Please, the next slide. Go back, please. If you look to this heart here, that's the heart after explantation, and the best description for his heart I got from my VAD coordinator. She told me the heart looks like it came from the grill because of the severe damage the heart had. Please, the next slide. Unfortunately, we were not able to repair the heart, and he got a total artificial heart, and that's the patient after the surgery. Please, the next slide. That's you can mobilize the patient while on ECMO, but the VV ECMO if you are going to go to the neck. That means also giving you other other possibility. Please, the next slide. That's intracontinental transfer. Please, the next slide. And that's, as I mentioned before, because of the technology we have, the anticoagulation strategies and protocols are very moderate. It's not that high as we did in the past. And again, a PTT level between 50 and 60. Only in the weaning mode, we are going to increase that level to 60 to 80. And that's it. There's no aspirin, no other drugs required. Only in patient having HIT, turned out to be HIT positive, we are applying adatrobal to those patients. And we have a couple of patients who have suffered GI bleed or other bleeding complication. We run the circuit without any heparin safely. Please, the next slide. And that's here our weaning criteria, which is really, I didn't see any patient here who suffered from acute cardiogenic shock and fulfilled this criteria and weaned and developed severe right heart failure afterwards. Please, the next slide. If that's the numbers we have in Hershey from the ECMO. As you see here, last year we did more than 80 years, but many of them were veno-venous ECMO because of the severe flu season we had this year. Please, the next slide. That's here the results. The summary of results in Hershey. We have more than 200 patients. Patient required ECMO for cardiac support, and we have 108 patients. We have about 55% patients survived to discharge. And after about 14 or 16 of them survived after getting an LVAD or a BiVAD or a total artificial heart. And if you, one might say 55%, that's not the big, and that's probably much similar to the shock trial. But please, I try to remind you with the inclusion criteria for such kind of patients. Expected mortality on those patients before we started to put them in ECMO is more than 75%. Also, the SOFA score of those patients is more than 13 in most of them. And patient required ECMO for respiratory treatment, we have 69%. We have patient here, group of patients who came to us because of advanced respiratory failure, but because of the severe hypoxia, they suffered hypoxic cardiogenic shock as well. And those patients, we supported them with the VA ECMO because we were not able to support them with the VV ECMO because of the hypoxic heart failure they developed. And those patients are they're nearly dead. We have 40% survival rate on those patients. We have other patients, we supported them with ECMO because of other indication, and like sepsis, extended life support, and drug intoxication, we have in those patients 35%. That's interesting to say that we have a demand now for our emergency department to extend our service to them as an extended life support measures. And we just started with this program in Hershey, and we hope to cover all the hospitals. We need more manpower to do that. Please, the next slide. That's my last slide here. I would like to underline the team work and team effort, because without having a team, we wouldn't be able to do all that work. And when I'm talking about the team, this team started first of all with our nursing staff, who is our eyes at the patient, who are giving us valuable information to assist this patient, taking care of the patient. I have mid-level providers doing fantastic job in the ICU, respiratory therapists, perfusionists, social worker, palliative care, spiritual support for the family. That's a very important point we have here. Palliative care, spiritual support for families are usually suffering more than the patient himself at that period of time, and we're paying big attention to this here. And we have got wonderful administrative support, research coordinator, and multidisciplinary MD teams, cardiologists, surgeons, intensivists, working close together to achieve these results. I'm going to stop here, and if you have any question, I'm more than happy to take them. Thank you so much.
Lauren has a question. Of course, our VAC coordinator of the year has to come up with something here.
Thank you. That was an amazing talk.
Thank you.
I mean, we know it's near as experienced as you, and I congratulate you on your amazing results.
Thank you.
it's not my area of expertise by any stretch of the imagination, but we do use a lot more ECMO, and you know, I remember the early days when you expected the patients to die and there was a bloodbath. My impression is over the last the last year or so, I think we're just making huge strides forward, and ECMO has become routine, and we expect patients to survive. From my point of view, thinking about VADs, the idea that you get full support, get them off the vasoconstrictors, you don't get gut ischemia, you don't get multi-organ failure. It's changing my world for the better because we're taking stable patients to theatre, and we're going to get better results because of the work you guys are doing. Comments?
Well, I think I agree on that. I'm saying here, time matters. If a patient in an advanced cardiogenic shock and multiple inotropes, and before organs, every minute or every hour the patient is going to spend on that on this inotropes is going to make a damage to the organs. If you can capture this patient area, you're preventing the damage of this multi-system or the multi-system organs, and that's going to help you improve this patient. And I'm saying also an additional point: those patients now are not suitable candidate to go for long-term VADs and expensive therapy. If you have a patient with advanced cardiogenic shock, multiple inotropes, and Intermax, I'm not going to say Intermax 1 here because they are below Intermax 1. That Intermax 0 and -1. That's what I have to say that. This Intermax is not appreciating the organ dysfunction in this patient, because you might have patient Intermax 1 have a creatinine of 1.5, and we have another patient Intermax 1 have a creatinine of 4. That's totally different story. That's why that's really patient below Intermax 1. And those patients going to the operating room, putting them very expensive LVAD or BiVAD is going, some of them are going to survive, but it's misusing the resources we have. That's why it's better to optimize the condition with those patients with an ECMO. Additional thing on ECMO in those patients is going also to fine-tune the right heart. Many of these patients, if you're going to start to put them on a VAD at that time they came to you, you might need a BiVAD. But if you're going to support them for a certain period of time with ECMO, that many of them, you're going to tell them from a BiVAD to an LVAD patient, which was a much, much better outcome and also quality of life. That's why I appreciate that.
Okay, thank you very much.